And at Kunda Kemirembe, we are residents in the Department of Psychiatry. Actually, Dr. Raymond Mugume is now an associate consultant in psychiatry. He took us through day 1 and day 2, where we've looked at everything from epidemiology to neurobiology and etiology, cause of substance use disorders. So today we shall be looking at the principles of treatment. Please remember to ask questions. We shall have time at the end for questions. And at 20 minutes past 7, we shall have a poll, an online poll for you to give us feedback. And the Neurotorium website is also available for us to consult, for us to use the resources and to subscribe. Thank you so much for joining and keeping time. Over to you, Dr. Mugume.
Good evening, colleagues. I don't know, am I loud enough?
Yes, please. You're very audible.
No background noise, eh? From
No.
my end. Okay. So I know that yesterday we didn't take up questions. We had said that we'll take up questions today. From yesterday's discussion, I don't know if you could help to moderate that for the case of questions, or should we take them at the end of this presentation altogether? Hello.
Yes, Dr. Mugume, you're right.
Do we do the question and answers from yesterday's presentation, or we should do everything all together after this?
We had told them to save their questions for today. So if somebody has a question, they are free to ask right now. Then we go a question about yesterday's session. Then today, at the end, they'll ask questions concerning today's session. So they are welcome to ask.
So sorry, my network is not nice. So today we're talking about treatment and intervention principles. And this is really a recap from yesterday's neurobiology, how we understood the reward circuitry, as well as the reinforcement that comes with using substances. And we looked at the areas that are usually affected. Okay. So in the overview, what we need to know is that there have been historic attitudes, of course, that have been variable in terms of how we view substance use. Is it as a positive? Is it advisable? Is it a moral failure? Are people very weak? Are they stubborn? Is it because they're doing it because they want? And some of those things, of course, there are also social theories that have come with it, need to be taken into consideration when we think about treatment principles. And as of 2012, the British Association of Psychopharmacology came up with 13 principles that we need to always look at. And of course, you don't only look at the substance use the person has, but you look at the person as a whole. You look at their family, their environment, their social spaces, and of course, you look at also if there are any comorbidities that the patient has, and then you also manage the addiction. And we need also to be reminded that addiction, again, is chronic, it's relapsing, it's a medical condition. We cannot cure it, but we can manage it. That is important to take note. And so some of the approaches that have been noted is that we have what we call detoxification. This one is usually more prominent with alcohol. If the patient has an acute episode, they have gone binge drinking, or they have been drinking as usual, but then they are brought to the emergency. What can you do? That is what we call detoxification. There are also interventions that we can work with their social spaces as well as their psychology or their mind, okay? Those are what we call psychosocial interventions. We have what we call contingency management, where we have patients in contingency management, really. We are trying to, it's as if we are trying, contingencies to do with like preventing disaster from happening, okay? Then it is also important, the other principle that we need to keep in mind is you need to create like an ambivalence for the patient. Let's say, how do you create that? You ask the patient, so since you've been drinking maybe for 2 years, 10 years, 6 months, what are the good things you have improved, you have enjoyed? Some people will say, I have friends, I am able to sleep, and then you also ask them, what are the not so good things that you have achieved? We kind of modulate our language. We don't say what are the negative things, what are the bad things, because by the time they come in or they have been brought in, their families have already told them all sorts of negative energy. So we kind of
Dr.
modify the language.
Mugume, kindly come closer to your device. Your voice is growing distant. So sorry to interrupt. Please come closer to the device.
Okay, and now? Am I audible?
You're audible.
Okay.
Thank you.
So I'm talking about the treatment approaches, right? That we have alcohol detoxification, we have psychosocial interventions. I've also talked about the contingency management, which is really about managing the, like we are like trying to prevent disaster from happening. Then we have motivational interviewing, which is really you ask the patient about the good things and then not the so good things that the patient has achieved. And then in that as well, you also ask about the patient's stage of change. And we shall look at those stages of change. If they're in the first stage, usually you provide more information, you
Thanks, Dr. Katama. I think in order to maximize the time, we can have those who had questions yesterday asking them, and any of us can address them. We also have our Professor Nakasuja Noelin. She's on the meeting. You're most welcome, Professor. I also welcome Dr. Mpamizo Emmanuel. Thank you for joining us. And thank you all members for continuing to join us for these sessions. Thank you for your patience as we wait for the presentation to come on. Those that did not get a chance to ask their questions, please feel free to ask now. I also would like to remind you that the Neurotorium website is available for these resources and more. All slides in the different topics are available, as well as the recent research findings and some educational videos and many other resources. So please look for the Neurotorium website. We shall put it in the chat. Subscribe and utilize the resources available there. Our presenter is back, and as he organizes his yes, okay, well,
I heard it got done, but I'm here. So I was saying that these are the principles, and what we need to know about these principles is that no single treatment is really appropriate for everyone. So there's no size fit for all, and the treatment needs to be readily available wherever you will be. And effective treatment is one that meets all the multiple needs and not just the drug abuse. And adequate treatment is when you remain in treatment for an adequate time. And usually that time is either 3 months, but it can be more. And that there is monotherapies don't really work. So we have to think about using both the non-pharmacological and then the pharmacological therapies, okay? As well as treating not only the patient, but also the group, the friends, as we usually see. Medications, of course, are very important element in this case in many of the patients, but especially if they are combined with what? With the non-psychopharmacological treatments. And then the other thing that we need to know is that we need to always individualize treatments by having plans, which are, of course, for services and also for the treatment. And this should always be evaluated continually and modified as needed. And then that patients who have drugs abuse, they also have comorbidities of other mental disorders. So it is always important to look at that. And when we are dealing with patients, especially those that with substance users, we need also to always know that treatment does not always have to be voluntary to be effective, okay? If the patient has been brought by their parents or by their relatives, you still give the treatment as you would for a patient who just brought themselves, okay? And that also that what we also need to know is that we need to continue monitoring if the patient is using drugs while they are with you in the hospital, while you're also managing them from home, you still need to do those drug urine tests. You need to ask the questions, you need to ask their relatives, because some of these things we are not usually asked. And that also treatment programs, especially for patients, let's say maybe they've been using injectables and then they get HIV, they get hepatitis C, they have hepatitis B, TB, and other infectious diseases. All these need to be treated, but also we need to prevent them or to provide risk reduction counseling for these patients. Should they have the diseases, we should manage them. Should they be at the virtual, should they be at the risk, we should also be seen to provide such risk reduction counseling. These are the components of a comprehensive drug abuse treatment. That, as you can see, we are not only, we are using the biopsychosocial model, okay, by Igel as postulated in 1978, that we look at the biological, which is usually we use a lot of drugs, okay? We look at the psychological, where we use the psychological tools, we do psychoeducation, then they do behavior interventions, and then we do this the social, where we do skilling, we do integration back into the community, and then linking them to other services within the community, because most times the patient does not need to be in hospital all the time, okay? So as you can see, we have family services. We look at if they are homeless, we try to work with the housing department and transport services. We have to link them back into getting jobs so that they can earn a living and be able to cater for some of the medication or for the medical services. Then, of course, also integrating them into the local services next to them. They don't have to travel all the way from Karamoja or come all the way from Uganda going to Nairobi and vice versa. If they have the infectious diseases, they need to get the treatment, colleagues, okay? And then, so that then we can talk about the therapies, of course, the non-pharmacological and then the pharmacological, as we shall see. So this makes it a very comprehensive treatment plan for anyone who presents with a drug abuse or substance abuse and other addictions. And these are all evidence-based, okay? The things that I will touch as we go on. So let's start with the non-pharmacological therapies. These are the psychotherapies and other interventions. One of the ones that I have mentioned is the cognitive behavior therapy, and how it works is that it's just, we look at how your thoughts, what thoughts are you entertaining? What thoughts do you have? Some people say, maybe I want to fit in a group, a certain group of elites or people. I want to be like that bad guy. Today I saw a patient who said that for him he's been using because he wanted to look cool. And because, again, we get this from social media, from media, we have seen maybe people, we admire the musicians using them, and we want to emulate the same. Okay, these thoughts always affect or they create emotions, and these emotions usually come with feelings, okay? How you feel in that state. Are you angry? Are you happy? Are you excited? Do you feel like you can now see a drop of water drop down? And these emotions later affect our behaviors, and then the cycle goes on, and then the behavior reinforces the thoughts, and on and on and on and on. So one of the principles that we that is done in CBT is that it is really one is that we want to control the influence of the person's emotions and behavior on the thoughts, okay? Because we cannot see the thoughts, to be honest. And sometimes patients will lie to you, and you look like maybe you didn't do your job well, but that is what it is. That the patients, you have to be very kind with yourself, and also we want to also manage how people act or behave, because this really usually that is the whole agenda in cognitive behavior therapy. Like you need to ask the patient, what are you thinking? What does that mean for you? What feeling did you entertain, or were you feeling, and what did that? Colleagues, again, internet is not my best today. I'm sorry, but we shall continue from where I was saying, and then so that is what is with the cognitive behavior therapy. And this is evidence-based. Really, it is not hearsay, it is not witchcraft, but this is evidence-based. The other thing that we need to look at other psychotherapies, that cognitive behavior therapy really includes a lot. We have heard of the electrode. We use it in almost every mental illness, whether patients have only substance use or they have comorbidity, we still use CBT. Just the approach maybe might be twisted, and again, individualize that for the patient that is in front of you. The other psychotherapies that have been evidence-based, that have showed good progress, is the community reinforcement approach, where you introduce changes such as abstinence. So like people who abstain, let's say you have had people say that I used to use alcohol maybe for 10 years, but I've spent 2 months of not drinking. What you can do is in a very simple way is maybe you can start with a thank you. You can encourage them to keep pushing a little bit. Sometimes people have those who are in a well-established environments. They give them vouchers, vouchers, not vouchers, vouchers for maybe going to shop or going to take a trip or going to visit their loved ones. And that kind of encourages the person to keep pushing, okay? The other rewards that we can work within our environment really is, apart from a thank you, is to ask them to talk about it, okay? To share their experience, because in a way you're encouraging them to know that, okay, you see, the problem is not with you and you're overcoming it. That is what we can do. And then the other thing that we can actually do, what this does in encouraging them, is that you're kind of positively reinforcing them to continue abstinent, okay? Rather than usually the what happens. Then we have the contingency management interventions, like I said. Again, these ones also enforce abstinence. Okay, I interchanged the two. The vouchers and the price incentives are in the contingency management. And then in the community, they can sometimes also apply, okay? They can also apply, but they have been more documented in contingency. In community, usually it is, you encourage the community to apply some of these things, okay? That you would do with an individual, but now it's on a community level. The community starts from the people that the patient stays with, their friends, their family, then their church, okay, that becomes the whole community. We don't determine the community for the patient unless they tell you what is their community, okay? Where they come from. Then the contingency management is where I was talking about the vouchers and the price incentives. And then, of course, we have things like mindfulness, which really helps the patient to recognize their thoughts, to alter the relationship they have with those thoughts. Maybe if they are feeling less of humane, if they are feeling weak, if they are feeling maybe they cannot do life without the substance, you kind of help them to think about those thoughts, and so it is a technique that they help them to detach from those thoughts. And it is mostly used with smoking cessation but again, evidence is not, it has not been applied within our settings, to be honest, so I cannot speak much, but it is well documented. This is just really to again show the effect sizes of what non-pharmacological treatments are like for the different substances, and how effective they are. Again, they're evidence-based. We have what we call brief interventions. Brief interventions are usually between 5 and 10 minutes. You have the patient with you. You don't have a lot of time. Maybe you're busy, or maybe the patient is saying that, me, I'm tired, I want to go. These are things that you can do very quickly to check the patient's behavior and also motivate them about reducing their intake with alcohol. It is usually with alcohol, but also you can use it sometimes with other substances. And so I talked about the stages of change, the cycle of changes that you have the pre-contemplation. The patient has some wisdom, but they're in denial. Most times they're in denial. They will blame it. They rationalize in this stage. And in this stage, you cannot do much. Even if the family brings them, they have handcuffed them, they have paid a lot of money, but the patient rationalizes, blames it on something, downplays it and says, me, I don't drink actually. I see I'm making a lot of change. I'm surviving, I'm thriving. You can't do much as a doctor. So one of the things that you can do in that stage is you screen them. Screening is one thing. You can do a cage, you can do all the other tools I told you about. You give them the results and what they mean. Okay, of course, with the urine drug, maybe you do the liver function test, you explain to the patient what these results mean and what they would look like if the patient does not check their drinking. Then you also give them information. This information includes where treatment is, what kind of treatment is available, what options are available, because sometimes we only talk about preventing abstinence, we never talk about harm reduction, okay? And then you also talk about the risk reduction counseling, where the risk to infectious disease, hepatitis B, hepatitis C. You also do provide that information. You link them to their nearest offices, maybe child protection or housing and finance. That is in the ideal state. In our setting, usually, if you have checked and maybe there is child negligence and what you want to connect to bring the child protection unit of police on board, together with the social worker and the psychologist, okay? Then in the contemplation stage, they have gotten the information, but taking the first step is hard. They have the information, they have understood it, but then they contemplate now. They think about their friends, the ones they've been drinking about, the shame that will come with not going. They think about the shame they brought the family. So they're in the contemplation stage. Again, you provide information and give them time. Don't force it on them, but give them time. You can do the harm reduction here. They'll be able to do the detoxification. You'll be able to give them maybe the prophylaxis, the thiamine and all these other things. Then preparation is the patient is actually willing to take the first stage, okay? They have prepared themselves, they have looked into it, they have reflected on their life, and they're like, you know what? At the end of the day, it is my life, I need to do this. In action, they're actually now taking the step. Some of them will tell you that I've spent 1 week without drinking, without smoking, they have not gone to the bar, have not met those friends that they usually go out to, and that you have to encourage it. You have to applaud them for taking that step or that action. If you have initiated them into the action, if you have gone into therapy, they continue with the therapy, and some will maintain, okay? Some will maintain, they will continue coming in. The longer they stay in treatment, the better. Some have joined the Alcohol Anonymous or Nicotine Anonymous or Cannabis Anonymous, and they are staying in that treatment. However, some will relapse, depending again, usually it is more like how we patients come to hospital and then we send them back to fire, right? The fire is that they're in the environment where they still have these challenges, okay? Without addressing those challenges, without tackling those challenges, we'll keep seeing these patients more and more and more. So relapse prevention is part of, it should always be part of your actions, members. It should always be part of our maintenance and treatment. Relapse prevention is one thing that I think is not emphasized more. And there is relapse and lapsing. So if a patient comes back and they, in that 1 week, they drink 1 bottle, it's not a relapse. A relapse has to be that you have taken a bottle, but maybe more times, maybe in a week you found yourself drinking every day. If someone drinks 1 day in a week, 2 days in a week, we cannot call that a relapse. It has to be at least for 4 and above days that they have gotten back to the what? The substance. Okay? So that is what we need to know in what we do in brief interventions. Motivation interviewing, I already talked about it. It is a technique used in counseling where you check the person's attitudes about changing behaviors, okay? You explore them and hopefully you resolve those that can be resolved in that moment, okay? If someone, you ask them the good things, the not so good things, you ask them about what if they found that maybe their liver was failing because of alcohol, or maybe they tell you maybe they slept with, they had unprotected sex, and you ask them like, what if you got, you know, an infectious disease, either an STI or HIV, among others, you know, you try to resolve some of those, you create like an ambivalence, but you always veer towards changing behavior, okay? And it's not an easy task, but creating that ambivalence helps the person to reflect on their life, to reflect on how they are living, okay? And this is what we need to know about motivational interviewing. It is been found to be very effective, and it helps patients to reduce on the intake of the substance. It doesn't compared to no treatment, compared to when you just see the patient and you be like, now what do I do? Okay, so it is very important. Then we have what we call the 12-step program, which is promotes acceptance among people who have used the same substance. They share their experiences. They share that addiction is a chronic substance. So like there are people who have used the substance. They sit together. They usually sit around. Fortunately, it has always been centered around religious houses. Okay, like in Kampala here, we usually there are those that sit around St. All Saints Church, Nakasero, and other. Usually they are around the religious centers, and they meet. They usually have a leader, and they will only accept you if you have gone through the first stages. You have been detoxified. You've been in the action stage of change. You've had treatment. They don't accept patients who have really not gone through that first process, the one I've explained to, okay? And they also try to encourage each other that the willpower is not usually enough to overcome addiction or the problem, okay? But usually abstinence is the only alternative, okay? Abstinence, the 12-step program is really to help to maintain abstinence from the use of a substance, okay? And this is what is done here. And these are some of like their rules, okay? That we admitted we were powerless of alcohol, that our lives had become unmanageable, okay? That is a level of acceptance that even sometimes as a clinician, I find hard to give the patient. But in this program, in this group, because they have all been at the same, they have been through the dungeon, and they have come out, they kind of encourage those that are starting the process, the steps. They have been abstinence for some times to keep the umbrella up, that abstinence is the only alternative moving forward, okay? This you can also again get through. It is really very encouraging, but again, it is something that we can look into. Let's go into the interesting bit where people, you know, started asking from Monday, pharmacology. Now, I need to also make a disclaimer moving forward that these therapies, again, from the yesterday's neurobiology, cannot explain why these medications, as much as we give them, people seem not to recover. And so that brings us to get interested in doing the gene-wide association studies, to be interested in the genetics in psychiatry. Okay, that's the disclaimer I wanted to make. Nicotine replacement therapy is one that we use in nicotine use disorder. We have gums, we have patches, we have tablets as well, to replace, instead of smoking, we do nicotine replacement with those patches, okay? And they're already on the market. The other drug that we use is bupropion. It is a dopamine noradrenaline modulator, but it is an antagonist on the nicotine receptor. You remember the nicotine acetylcholine receptors? It works at that stage, and we saw how the nicotine receptor modulates the release of dopamine, okay? You remember that when you smoke, and nicotine attaches on the nicotine acetylcholine receptor, you have a surge in dopamine. So bupropion helps to reduce that. Then we have the vinesilin. That one I've not met it in our surroundings, but it also works on the nicotine acetylcholine receptor on the subunits alpha and beta, alpha 4 and beta 2, okay? This helps in reducing the rewarding and that reinforcing kind of cycle that happens with smoking. In addiction, alcohol addictions, we have detoxification. Detoxification, what we usually use is that when the patient comes after we've done the assessment, you want to first manage if there are any withdrawal symptoms. So we usually give either a benzodiazepine, is usually the first line. We give, if they have the craving, we can give either, I will not give you the milligrams per se, because again, this lecture is not to make you an expert or a psychiatrist or an addiction expert, but really is to give you wisdom and to always help identify and signpost or sometimes use, okay? We have disulfiram. Disulfiram works on the aldehyde dehydrogenase, and it is the effects are usually not very good. If you have ever taken metronidazole and then maybe you drink alcohol, those effects that you get is what disulfiram gives you, okay? It's really not, it's not, because once you block the aldehyde, acetaldehyde dehydrogenase, you have a buildup of aldehyde, and aldehyde really is really, it gives you nausea, you will vomit, you can end up being in an emergency setting. So we go through on disulfiram. I've not used it, and I don't know. But then we have naltrexone. Naltrexone is works on the mu receptors, the mu opioid receptors as an antagonist. And it helps in that urge or to use alcohol, okay? You can give it, you usually give it for a fortnight, 2 weeks, and then you revisit the treatment plan, okay? We have then nalmefene, which is again a selective opioid receptor modulator. This one works both on the mu and the kappa, but mostly on the mu, and it is used in alcohol because we learned yesterday that alcohol works through the endogenous opioid system, you remember? So that's why we are using these mu opioid antagonists. Then we have the acaprosate, which really works on the glutamate and GABA. Acaprosate, you remember one of the drugs that works through the glutamate and GABA is the opioids, okay? So acaprosate can come in handy in opioid use disorder, but also it is very much used in the alcohol use disorder. Then when we talk about opioids, especially the opioids, and then the opioids, usually the synthetic opioids, the fentanyls, the tramadol, the pethidine. Usually that one, again, we can use some drugs here, like the naltrexone is one of them that we can use. It's an opioid, of course. In this case, it would be an antagonist, but in cases where we have like heroin and heroin, there's heroin, we have the cocaine, we have the fentanyls. Those ones we usually refer you to the medically assisted programs. We have one in Uganda, it is at Butavika, but for you to enroll, you have to go to Maki, India, to get the service, okay? Methadone is a very controlled drug. Its efficacy, it is like 30 times the use of marijuana, and then buprenorphine works almost also in the similar way like methadone. These ones are bind on opiate receptors and they're agonists, okay? They have a longer half-life, okay? But buprenorphine is also a partial agonist at those, it's usually for it, it's a partial agonist. but these drugs are controlled under the under NDA. So you have to have reason, okay? And then for tobacco use disorder, nicotine use disorder, I've talked about the transdermal, the patches, the gums, the lozenges, the inhalers. I haven't seen a nasal spray, but we have also the sublingual tablets, okay? And again, I've talked about how they work. Then I've also talked about the treatment that we use in alcohol. This is where disulfiram works. Let me use the pointer here. It works here, okay? Disulfiram works here, okay? And then when you use drugs like maybe patients are given benzodiazepine, why were we giving the benzodiazepine? Benzodiazepine modulates the GABA A receptor, okay? So somehow ethanol is not, it competitively inhibits ethanol from attaching at its core receptor on the GABA A, okay? So modifying that site at the receptor. So that's how we give it, but also it is very important in withdrawal alcohol, in the alcohol withdrawal syndrome. If you have seizures, the tremors, sweating very fast, the benzodiazepines usually work very better. But then the naltrexone is also, I've emphasized that. Some of the withdrawal symptoms that we usually want to look out for in acetaldehyde buildup is skin flushing, the tachycardia, the hypotension, shortness of breath. So you need to have either an ICU and HDU, because once you attempt, if you ever prescribe disulfiram, please keep the patient next to you, because it's usually not a very, especially in our settings, okay? Then medications used to treat opioid use disorder. Of course, I've talked about the agonists or methadone. The partial agonist is the buprenorphine. Then we have alpha-2 adrenergic agonists like the clonidine, propranolol. There are some of the drugs that we use, but usually here we use either substitution or replacement. And this has been the established therapeutic approach. In countries like Kenya, they have even those mobile medically assisted clinics, okay? But at Madari, they do that very well. They have, and even in Tanzania, they also, I am well informed about how our neighboring states are doing in terms of alcohol addiction. They are really at their best. We need also to start thinking about addiction in a public health policy versus law enforcement, because most times when we have these drugs, we forget that it is a public health issue. So we always want to firefight and then send back to the community, and then they are brought back. But maybe it's high time we start thinking about the challenge that we have found in treatment and how we get frustrated, okay? One is to understand that there is an increasing, Uganda used to be a transit site. Now we are also a hub of drugs. We have what we call drug hubs here in Kampala. And that is no longer, it's now common knowledge, okay? But we need to understand the challenges, the high levels of opioid use disorder in the Americas, cocaine production, of course, in South America. We have HIV among our people here in Africa. Then plus drugs, you can see it is a cocktail of issues and problems, okay? So it is high time, of course, in Australia, you have high level use of stimulant use. So the cocaines, the amphetamines, methamphetamines, they are used there, okay? So substance use and criminality. I will give this as from what I got to know when we are rotating in Rosetta prison. We found that there is a high crime rate when people use substance uses, okay? They will end up either killing someone, they will end up raping, they will end up stealing. There's a high criminality that comes with substance use. So that is why we also need to engage the law enforcement, the law, the judiciary, when we start to have these discussions. And I'm glad that we were able to have our first session where medicine meets the law. And I hope that that will continue for us as a country. But also, the war on drugs cannot only work with only healthcare. We need maybe to start also taking an approach as healthcare workers to maybe start understanding the law. or maybe working, studying law at the end of the day, because why not? We should be able to do that, and maybe we can work with, we can come up with policies that are better, can better address, because once a person uses a drug, you put them in prison, then you release them because that's a controlled environment, then you release them, they will start from
Dr.
where they
Mugume.
began from. I'm
Dr.
concluding,
Mugume.
members. This
Okay.
is all about the public health and policy and what has been done. So there is the Manila Declaration. You have heard of it. There is Rodrigo Duterte was the president of Philippines. He launched that campaign to curb the problem of illegal drugs in the country. Was it successful? No. Did it spark criticism from human rights organizations? Absolutely. But it can be seen that again, he was trying to see public health, public policy, and the law and health. That we can draw some what some something about it, okay, some intuition about it. Of course, 20 years of decriminalization of drugs is again the same thing. We cannot keep decriminalizing the public or those who use drugs. We need to address what we have understood from this tutorial, okay? We have some innovations on addiction, okay? One of the things is that how do we increase adherence to these therapies for addiction, okay? Are we doing enough with health literacy? Are we involving the patients enough? Is this care readily available? Are the healthcare resources available? What is the nature of the drug? Do we even understand it? How is it delivered? How do people access it? And that complexity is what is missing, okay? So some of the things that we are looking at is telemedicine and internet-based therapies, where you can now teleconsult, and maybe texting, making videos, mobile apps, and also telephone-based therapies. Like a patient just logs in and then they can continue. This was attempted in COVID-19. What is the prognosis? The prognosis of substance use disorder is similar to any other disease course outcome and other chronic diseases like diabetes, hypertension, HIV, among others. That the first episode of intoxication will likely occur between the mid-teens, okay, maybe 13, 14, 15, and then the age of onset of alcohol use disorder is usually in the late teens, 18, 19, 20, okay? And then thereafter, if it is not curbed, then we shall see these patients in their late 30s. That's when we will make the first diagnosis of alcohol use disorder. People will have alcohol dependency, and once they do have, they will have social and psychological and physical comorbidities, okay? They probably come because either their liver failed or their kidneys are not working well, and so we need to be aware of this. The cause of alcohol use disorder is highly variable in the individuals, so we need to decide who will abstain and who we need to respond to a crisis very quickly and who will resume to alcohol use in the shortest possible time. Tobacco smoking or nicotine use disorder usually begins very early in life, before the age of 23. In fact, one of the studies here done by Dr. Naru just said that by the age of 6, some of the children have already started alcohol use disorder. And opioid use disorder can occur at any stage, and it does not know whether you work in a bank or you're a wananchi, you will be affected, okay? So that is something that we need to know very early moving forward. Virtual reality is also one of the other interventions should have come after the internet. This one is still being tested. At least IDI, the Infectious Disease Institute acknowledgement, is trying to first test it with these infectious diseases. Maybe it will be time that we also apply it in our setting. Self-injecting rooms, again, these are part of the harm reduction avenues that we are using. Self-injecting rooms, where if you provide the injections that are safe, that are sterile, you supervise the facilities and try to provide overdose prevention centers. The aim is really to reduce the risk of disease, prevent overdose-related deaths, and then connect people with substance use to addiction treatments. And in summary, treatment is both pharmacological and non-pharmacological, okay? Depending on the stage of what we can use is brief interventions, and motivation interviewing techniques are very important for every patient that you meet. And then you can always post them for CBT and two-step facilitation. Pharmacological treatments are very wide, and they include replacement therapy, among others. And no one therapy is superior for treating people. We shouldn't think that one therapy is superior over the other. They work hand in hand together, including even patients that want to say they want to go to church or want to go to the mosque. Do not stop them, okay? So long as you can work together. You always have to strike a balance between public health policy on one hand and the law enforcement on the other. Adherence to treatment remains a big challenge, and that is one thing that we need to look out for or research more about or have ideas on a round table. We also have to be aware of the new innovative approaches that we can come with to address the issue of addiction. Thank you very much. I'll be glad to take in any questions.
Thank you so much, Dr. Mugume, for that in-depth presentation. Clearly, you did your research very thoroughly, and I'm sure a lot of information, a lot of knowledge has been gained. Members, thank you for attending and being patient with the hiccups. Please post your questions. You're welcome to give us questions right now for the presenter. And we are going to have an online poll. The link will be shared shortly. In the meantime, let us have your questions. Thanks once again, Dr. Mugume. Actually, the poll has been shared. Kindly provide us with feedback so that we can do better in the oncoming sessions. This week, we have covered substance use, addictions, and we are going to have a series for 5 more weeks. This was only week 2. So our next, I hope in the meantime you're answering the online poll, members who are present. We are also going to look at schizophrenia. We are going to look at Parkinson's disease, Alzheimer's disease, and we really want to give you the best. So that's why we are taking this poll, so that we have feedback, we know where we can improve and where you appreciate it. Thank you very much. I've also posted the website, the Neurotorium website, where we can go and get some of these resources. You realize we really rushed the presenter. He had prepared tremendously, but some of these things we cannot package it all during the presentation. So you're encouraged to go to the website. Yes, there's a CPD, there are CPD points available. Dr. Mwanguzi will advise us on how to register for them.
Dr. Kimirembe, let me share the link as you respond to the question in the chat.
All right, thank you very much. So Sandy Apollo is asking, how shall we get maths clinics across the region? For example, Southwestern, because we have ghettos that are abusing drugs. And Sunday is also saying that methadone is helpful. So the question is, how shall we get the methadone clinics across the country in regions like the Southwestern region? We know that this problem is widespread. Over to you, Dr. Mugume. I also request input from our seniors. Some of these questions are above our level.
Oh, thank you, Dr. Mugume, for the presentation. So before I respond to the issue of spreading out the methadone clinics, I just want to throw light on the use of aversion therapy in the management of addictions. So Dr. Mugume kept on saying that you really shouldn't give one of the medications because of the side effects that the individual will feel as a result of accumulation of the aldehyde. Indeed, that is the whole intention, that when this individual takes the drug, the aldehyde accumulates and causes such a bad sensation within the individual that creates a dislike for alcohol for subsequent use. Now, for you to gain an individual's cooperation in taking the drug, of course, they have to accept. They have to know that the feeling they will get should they take any alcohol will be similar to the way they felt before when they had some alcohol in their system and they happened to take the treatment. So you just need to have cooperation of the individual, and I have seen patients who willingly will want to have their medication taken so that it deters them from taking any alcohol subsequently. On the spread of methadone clinics, the issue is the cost of giving this medication and the probability of abuse still, even though it helps with withdrawing an individual from heroin use and constant usage of drug. With the methadone, they spend less time trying to access these medications, but the issue is the cost, and the government has to, play a role in ensuring that this is available. The hope is that this, if a bigger budget is given to mental health services, that these are things that will be spread. Even the one we have in Butavika already is an inconvenience for people to move all the way from wherever they may come within Kampala to travel all the way to Butavika. In other places, they try and locate these places nearer to where those individuals are at, so that they can kind of stay in gainful employment rather than moving around looking for their fix. But of course, which is much better than when they were on the heroin or other opioids that consume their time in looking for them and using them. Over.
Thank you, Professor Nakasuja. We are glad to have you to give input in the discussion. Sunday Apollo, I hope you're satisfied, and you're advised to tap the bottom of the screen so that you can get the poll. Thanks once again, Professor. Do we have any other questions?
Dr. Kemirembe, just a clarification for the people looking for the poll. They should go to the bottom. They check at the extreme right. They're going to find an icon having more. When they tap the 3 dots on more, it will bring for them options, and one of them is polls / quizzes. They will tap that option and the poll will display on their screen.
Okay, thank you for that clarification. Our time is up. I'll just give us 30 more seconds in case there's a question. We can take a minute and answer it. Otherwise, I thank you all for attending. Please share with your friends and your colleagues so that the next session has a bigger attendance, because it's really a lot of information and it needs to be shared. Thank you, the team that's behind this. Thank you, Dr. Mwangzi, for making it possible. Dr. Mugume, again, thank you for the preparation. Thank you, Dr. Mpamizo, Dr. Mwesiga. Thank you so much, Professor Nakasuja. We are always more comfortable having a senior around. We are glad you could contribute. Thank you all. Have a good night. It's now 8 p.m. See you again next week. We shall be using the same Zoom link, and we shall be meeting at the same time for our next series. Thank you.
Yes, good evening. I think now it's just us in the meeting. Well done, our dear presenter and moderator, for taking on today's session. As usual, we are doing a debrief. What have we noticed? What are the key things you have noticed in today's session that we can work on and do better? I mean, it's continuous improvement and work in progress. Even if it's the same thing you're repeating, don't get tired of repeating. And as usual, let's go with Dr. Mwesiga first.
Good evening. I didn't really attend because I was at the wedding. Actually, the last minutes I was in front. They were introducing us people. But at the end, I noticed people asking for CPD points. Maybe we should plan to, on the next plan, to deal with that. That one is quick. We can give them through UAP. And Moses, we are going to give the CPD points. So.
Yeah, we are going to input on the next flyer. Sure.
For the issues with the communication, that's why we have already said it. That's why we have two people, the moderator and the what. And so, Cameron, your job is to keep the time, but also keep the session flowing. These mishaps happen, they'll happen on the conferences, they'll happen everywhere. So, and then Raymond, preparation again. So, I don't know where you took the call from. So it's better to take it. So I don't know if we should now agree that where is the best place for at least the moderator and the presenter to see it. I don't know. But then we just need to have the content. I think that was on. So that's it for me to do.
Okay, thank you very much, Doctor. I don't know. I don't know if it's very possible to have grown a common place, considering also the time of this session, 7 p.m. But maybe we shall leave that for the team.
But we just need to have the content.
Yeah. Okay. Anyone else with comments? At least what we have noted from Dr. Mwesiga's. 1, CPD points. Ideally, if we have noticed, today's attendance was lower than any other we have gotten or registered before, which makes me wonder, are people not interested in the topic? Are people very busy? Didn't we reach out very well to our networks? Are people just getting tired of them, that they've had enough and now they feel it's becoming a usual thing that they can skip? I don't know what can explain the low numbers today. I do not know if we are all doing the sharing. It's very hard to track if the people you shared in the different groups were able to attend. Especially the students. I don't know. I feel like the previous sessions have been having students. Today we had a few, I don't want to say fewer, maybe still they made the majority, but compared to before, because the people I saw were mostly medical MOs, the ones I know, MOs. And I guess maybe because they expected CPD points. I saw some students also from the psychiatric clinical officers, PCOs. At least some from the class, the ones I could recognize were there. Guess they got the link. The students from Mbara, Gulu, Mook. I don't know. I feel like today's numbers among the students was lower than before. So maybe that.
Okay, let's figure out. Let's reach out to Mpamizo and figure out what's happening. Maybe there was an activity or something, and then we try and fix it.
Yeah.
Mpamizo, Aujo, Vibes, Mutume, and let's figure out what's up.
I had mentioned that you would share contacts. I know that I have a contact for Dr. Aujo. I do not have one for Dr. Mpamizo. I don't know. We could share the work, divide amongst ourselves, and make calls as we prepare for next week.
Okay, I'll share the numbers.
They mobilize, yeah. CPD points, Dr. Mwangs, you've said that you'll be able to get the link. I'm sure if we can include this on our flyer for next week,
sure.
it really many people attend, especially the MOs. They are looking for CPD points because we know that we are coming to the end of the year. That's when people renew their licenses. Another key thing that I saw, and I think that I do not know where the challenge is. We still didn't have Dr. Mugume in the preparatory meeting today. It's quite, actually for this entire week, we have not had in the preparatory meetings, and it's not nice to not be in a meeting where people are agreeing on where to do things, and then we come and, because the session started with asking what we should start with. And that took about a minute or two, by trying to understand, should we do the Q&A or not? Are we doing? And I did not think that was right, because it looked like we're setting the agenda from the session when everyone is, here. It didn't look like we are really organized well to start wondering what we should do first and what we should do next, and asking the moderator. And the moderator is also saying, I think yesterday we agreed that we do this. And she had now to go and look in the chat to find, the message that I shared yesterday, to send a screenshot. Had you been probably in the preparatory meeting, we would have set all this straight. Of this is what we are doing, this, and because somehow we thought we came here knowing what to do, so it didn't look nice. And hopefully in future we can do better, that we all come here and be on the same page and we just kick off. Otherwise, you did well explaining the content, and you're also confident. Please keep it up. Our moderator.
So when are the preparatory meetings? Let's agree.
So we have been doing 4 p.m. But today we pushed to 5 p.m. instead of 4 p.m. And I think Dr. Katama mentioned that he was seeing a patient at that time, and Dr. Mugume also said he was seeing a patient. And I think that's why he didn't,
So what time will they be next week?
Ideally, we should keep them at 4 p.m. Dr. Mwangus, but also we need to, doctor is on ward classes and all that. Dr. Mwangus, what do you?
I think 4 is fine.
4 is fine, or we do 5?
I think 4 is fine. 4 to 4:30, usually if we all log in at 4, it really takes a few minutes really, and we are done with agreeing on key things. So if we log in at 4, by 4:30 we are done.
Yeah. I think it's important that usually they help us. We don't really have a lot to discuss in those preparatory meetings. It's usually, what are we doing today? How is the session flowing? What is the moderator doing? What's the presenter supposed to do? And we're on the same page. And then we come and start. And maybe for the future moderators, kindly, if something, the reason as to why Dr. Mwesika suggested we have 2 people on every single day is for things like what happened today. You know, the presenter is not having internet, is coming in and out of the session on, as is just back, then it has left. It was a bit of, but if, for example, the moderator is also prepared and ready for anything, when the other one goes off, they just continue from where the other one stopped and we proceed, so that we don't keep people waiting for when the presenter will come back on. I mean, what if they don't come back on?
Exactly.
Yeah, so for the future, let's all our moderators know that you're 2 people presenting, except that we are saying let one present, one moderate, but should anything happen, you automatically have to take over. That's it from me. And maybe other people can also come and say something.
So we have agreed what time for the sessions?
I suggest 5. Dr. Mwesika, I heard you say 5.
I suggest 5.
Yeah, I don't know what the others say. Maybe can do
We
consensus.
adjust to 5 p.m.
On my side, 5 p.m. is okay.
Okay, that's okay. That's fine also.
I would even do like 5:30, and the whole idea is that once you have agreed, whoever is presenting and moderating, you don't really take up because if you do 4, someone will feel I can see one more patient, or I can review something, and then people get late. So if you sit at 5:30 to 8, and for just 3 days every 2 weeks, that should be okay. You can read the book in the meantime. So I would say 5, even 5:30 would be better.
Lillian.
Yes, please.
Yes, can I would like to make a comment.
Yes.
So you were wondering why people seem not to be having interest, and there may be very many reasons. But one of the first things I've seen is we don't seem to be making people think that this is actually an exciting thing. And one of the simplest ways of people picking interest in something actually is when it is shared, not by one person, but by several people. Someone shares, you tag and comment and something of that kind, which we don't seem to be doing. Whenever we see, for example, in the psychiatrist group or UAP or something, when someone has posted, we say, it is done. And the rest of us sit back and relax. But that is a basic. The more people share something, the more people wonder what if there is something special hidden behind what is being shared or something, and they join over time. So I think we need to take this a little more seriously. Share as many times as possible. When a colleague has shared, tag, say something. After some time, share the same message or forward to other groups and so on. Then the other people I was thinking about is, have we taken time to approach these PCOs from Butabika? I don't know. I think that would be another good group to approach.
I remember who was supposed to reach the PCOs, wasn't it Lillian?
Yes. So I have reached out to the students. I have failed to get the teachers up to now. And so the ones I have seen are majorly from my class. The teacher who mobilizes them, I have not been lucky enough to get him. And I'm not in their WhatsApp groups. So that's where the challenge is.
Okay, let me send it to Angel. Angel is in that PCO group for next week, and I'll ask her to.
For the ones, I don't know, I'm meaning for those ones, the students from Botavika. For the ones of the countrywide Ministry of Health Eco Group, there I keep sending them. Even today I sent there and they even commented, thank you for sharing. I even put encouraging words, please let's attend, it's good for psychiatric clinic officer, okay. Blah, blah, blah. But I don't know if some members attended, but I shared. I have been sharing for this. It was yesterday, today, yeah, this week actually.
So the people who are saying, you know, we're asking a question, is this time good enough to people who are already on? You know, there's that epidemiological fallacy, right? So maybe we should ask people who are not on if the time is good enough. And ask them what time they think is most appropriate. So on those groups that we are sending, why don't we send the poll? Instead of sending the flyer tomorrow, why don't we send the poll? But the biggest poll is like this final poll. Have you assessed the Neurotorium slides? Have you, and we add also, do you know about the series and do you feel the time is adequate? Something like that. So let's run a poll, let's get data. And we may just be assuming, but the people who are telling us the time is okay might be the minority. We might have to change the time. So instead of sending the flyer tomorrow, we send the poll. And we ask
you
if
send like a Google link, a Google link for them to tap and fill. Because a poll, we can't do a poll in our WhatsApp, multiple WhatsApp groups at once. One would have to set up a poll in each group, a separate poll.
Okay, yeah, so we'll do a Google poll, a Google Doc, a Google poll. Yeah, let's set up a Google poll. We may find that the time is just not. And we may just be listening to people who actually can come, but maybe the PCOs are parents and 7 is time for homework. They say no, 35, something like that. We'll have to think through it. So let's do that for tomorrow. Instead of the flyer, let's send. Moses, I feel whoever said their MOs, I would send them a link for CPD points. I don't know if that's possible.
It's possible. It's very possible.
Yeah, so look at anyone who is not a student, send them an email and let them click for CPD points so that they don't look like we are cheated them. I think then we'll take it. Yeah. Yeah. So let's do those two things. Let's run a poll in all those groups that Muyanga is talking about. When Muyanga posts it, I will say hi everyone. We are trying to get to ensure that the timing is perfect and that we're using the resources. And we do it maybe like tomorrow and Sunday so that we have some information by then. Then I will share the flyer with the. Actually, wherever we are planning to send the flyer next week, let's send that poll tomorrow. Let's just get a Google Doc and send the link and the stuff.
So that means we shall have to create a Google form, or we can use any other platform, and we add those questions. I think I can do that tonight.
Can go out first thing in the morning and we know.
Okay.
Yeah.
Okay. So what we get from this is one, we get contacts or we contact the leaders in the different universities or institutions. Two, multiple people should share the flyer, you know, to hype up the sessions.
The link first, flyer.
Sorry?
The link, tomorrow we're sending the link, then after the link, we'll send the flyer. So multiple people should send both the link and the flyer.
So the link with the Google document that is asking about time, eh?
Yeah, so asking about Neurotorium, if they have heard about the series, if they've accessed the slides, if there's any issues, like 5 questions. Because if someone has heard about it and they say yes, then you ask, is the time okay, or would you suggest a change? Something like that. Moses, you can send it to me and have a look at it and I guide.
Oh, sure.
I think for me, the most important thing is that the preparatory meetings next week, we have agreed on 5:30, right?
Doctor, you're saying we start from 5 to 5:30, or you're saying we start from 5:30?
I'll defer to your expertise because you have done a good job, you and Moses. So whatever time you say, I'll defer. But I feel
want you people to attend.
I feel that if you do it later, people then have no room to do other things. And if you do it at like 4,
from those who have not attended quite regularly, to see what time they prefer.
Then
Because, yeah. What time do you prefer between 4, 5, or 6 is almost session?
I think we should ask the presenters because, for example, like today you saw we only had Kemi in a preparatory meeting. Remember, this is their show. They have to run it. It's important that you tell us the time that you believe you're actually able to attend these preparatory meetings, because if they are happening without you, it's not making sense.
Yes. I think an adjustment to 5 is okay. Yesterday and today I had one challenge. Today I had a patient. Yesterday I was actually in transit and I had poor network at that moment, but I think 5 p.m. is fine. Usually that time for me, I'm always settled.
5 or 5:30?
5:30, I think.
Why? Okay, so me 5:30. Katama is
because 5:30 meeting ends at 6. You can go and take a cup of tea, ease yourself, come.
For me, as long as
5:30.
As long as it is from 5 onwards, I'm available, so we can do 5:30.
Okay, I have not heard from Mugume and Kemi. Mugume and Kemembe. I see Kemembe is not in a meeting. Dr. Mugume, what time?
I'm around. I'm just, I think this week being the presenter. That's what I've been concentrating on. I do hear the comments with the proposition for the poll on to go out today. No, tomorrow. It's a good idea. Just I don't know if it is with the registration that you first have to go through and then check your email and get that, and then join in, which could be a factor to consider. Or if we can alternate it with people freely entering and then they register, of course, which has its own challenges.
No,
But maybe
Raymond,
let's
we're still on the question of the preparatory meeting. Should we do it at 5 or 5:30? The preparatory meeting.
Let's do 5:30.
Okay. Then for the issue of the registration, I would encourage all of you, the moment you register the first time, just save it in your calendars, in your Google calendars.
Yeah.
Then instead of going to re-register, just go to the Google Calendar and click the link. It goes directly.
Yes. Yeah, I don't know if it is timed out, because today it's what I was using, of course, apart from like the first 2 times it was the internet, but then the next 2 times it would just end me out, like it would like circle me out. So I wasn't sure if it is timed or.
No, I think that's data. So once you lose connection, you start afresh. So you just that's why it's good to have it in the calendar.
Okay.
You go and just the calendar. But okay, so we have said 5:30.
All right. Thank you, everyone. You have done a great job. The week is done. See you next week.
Hello, thank you. I think we have done a good job. Me, I don't want us to be too discouraged.
Well,
You don't know. I'm just saying, in case you want to be, don't be too discouraged.
okay.
At least the people who I can tell you that, well, maybe Moses, what are the answers of people? If you look at the poll, what are people saying about the slides and downloading them?
I was actually attempting to download that today evening. Let me check right here.
So at least the funder is from the feedback we have gotten. It looks like people are, at least there's a bit more traffic. So we're on the right track. If we just find more people downloading the slide, I think the key message is that there are so many people still out here who can access the slides and benefit from them. So we just need to. I agree with Muyanga that there's so much power in communication. I'm learning that in my middle ages. But, so if we just create a buzz, that's the buzz. That's the key word. You just need to create a buzz and should be effective. Okay.
Good evening, everyone.
Okay, Raymond, I love your confidence. I have enjoyed your presentation today.
Good night.